Good morning, everyone. On behalf of OneStop MRCOG, today we will discuss a very common station which comes in the MRCOG Part 3 exam. It is birth options after cesarean section. There's also a very common patient that we see day in and day out during our job as an obstetrician in the NHS. The station goes like this. You are seeing a 27-year-old para 1 gravida 2 lady with one previous cesarean section, which is done for breech presentation at 39 weeks without any complications in her last pregnancy. She's currently 24 weeks pregnant. Take a relevant history and counsel her about the mode of delivery this time. Now, there are two parts of this station. One is to take a relevant history, and the other is to counsel about mode of delivery. It might seem to you that it's a long station, but trust me, if you know what to say and if you're fairly confident, you should be able to finish this station off within time. Um, when it comes to taking relevant history, it should follow the lines of standard obstetric history taking. But just because, especially for this station, you'll be counseling someone about mode of delivery based on her previous obstetric history, you have to take a detailed antenatal, intrapartum delivery, and postnatal history of this patient with regards to her previous pregnancy so that you can counsel her appropriately. As you know from the station that this cesarean section was done at term and without any complications, so this was a lower segment cesarean section, in which case she would have the option to consider both a vaginal delivery as well as a cesarean section. Now let's come to VBAC first, which means vaginal birth after cesarean section. This is a standard terminology which is used in the UK, and you are expected to use VBAC. However, a patient may not understand VBAC. You have to remember this is a patient counseling station, so you would need to avoid medical jargon as far as possible. So you tell the patient that you do have the option to try for vaginal delivery. And if you go into labor the chances of a successful vaginal delivery is in the range of 3 in 4, uh, which means that there's a chance of emergency cesarean section in about approximately 30 to 35% of cases. She might uh, be confused regarding this value of 30%, whether it's high or low. In that case, you may as well say that in someone who is laboring for the first time in a first pregnancy, the chances of an emergency C-section for obstetric reasons is in the range of 20 to 25%. However, if she has had a previous C-section, the chances of an emergency C-section is approximately 30%. But you also say that, yes, vaginal delivery is safe because it's a vaginal delivery and you avoid cesarean section. But there is a small risk, which is the risk of the rupture of the womb, which is the rupture of the previous cesarean section scar. And the chance of that happening is 1 in 200. Although it is thankfully very, uh, the incidence is very low, but it is still a real chance because if a uterine rupture happens, there is a high chance that it can get critical for the mother and the baby. The risks include maternal internal bleeding, baby going into distress, baby being starved of oxygen, and if undetected, can sometimes lead to fetal demise plus or minus um, maternal demise as well. And that's the reason if she decides to labor this time or ends up laboring this time, she will be monitored exceptionally closely. She will need continuous CTG in labor. She will have an intravenous IV cannula in. Uh, Home birth is not recommended because there is a need of very close monitoring, which is only possible in the hospital setting. And also, very early scar dehiscence is usually detected by a CTG even before hemodynamic instability becomes apparent. You always have to reassure the mother that if in case we have any doubts or things are not going according to the plans, our threshold to call it a day and do an emergency cesarean section would be much, much lower. You also inform the patient that she has options for all pain relief in labor, including epidural analgesia. Tell the patient that the trial of vaginal delivery in women with one previous cesarean section is done in a controlled environment, and at every point we will listen to her and follow her wishes. If vaginal delivery is successful, uh, she avoids the complications and the risks that come with another cesarean section. Recovery is much more quicker, and if there is a successful VBAC this time, the chances of a successful vaginal delivery in her next pregnancy is in the range of 90%. Also, it improves the prognosis for future pregnancies. However, if in case she requires an induction of labor or augmentation of labor, the risk of scar rupture increases 2 to 3 times. However, induction or augmentation of the labor, if required, is a routine practice in women with one previous lower segment cesarean section. However, it is done in a very controlled setup, and again, our threshold to do an emergency C-section if things are not going according to plan would be much lower. You also discuss about elective cesarean section, the pros and cons of an elective C-section. If the lady opts for an elective C-section, it is done between 39 to 40 weeks, because at that time we would be assured of fetal lung maturity. However, the cesarean section done this time would be different from what was done last time, because we will encounter scar tissue and adhesions at the time of C-section, and hence this C-section would be technically a little bit more difficult than her last time. The risks include pain, infection, bleeding, injury to organs surrounding the womb or the uterus, like you say, like the bladder, bowel, ureter, blood vessels. Um, uh, there's a risk from anesthetic as well, because a C-section is done under spinal anesthetic. There is a small risk of clots in the legs and the lungs. There's a small chance of return to theater due to interval bleeding or any other complications. And with each cesarean section, there's a remote risk of hysterectomy to be required on the table as a last resort and a life-saving procedure. And the incidence is quoted as 3 to 5 per 1,000. You also have to mention that there's some research evidence which shows that there may be a small overall increase in stillbirth in future pregnancies in women who have a C-section rather than a vaginal delivery. You do have to mention this because this is mentioned in the consent form that we use to counsel women for C-sections here in the UK. You also have to tell the women about the benefits of a planned C-section. It's a planned procedure. It is done in a very calm atmosphere, so the woman feels more in control. And most cesarean sections go well, and women are able to go home by 24 hours. You do inform the patient that every C-section alters her risk as a surgical patient, and any future abdominal surgeries, any future cesarean sections becomes slightly difficult and high risk of complications. You also do need to mention about a few other conditions which are more common in women with previous C-sections, including abnormally invasive placenta, cesarean section scar ectopic. There's a need, and all her subsequent deliveries would be by cesarean section after this pregnancy if she opts for a C-section. And in her next pregnancy, if she goes for a C-section this time, the chances of scar rupture is in the range of 1 in 60 to 100. You also quote that there's some research evidence which shows that there's a slightly increased risk of childhood asthma and childhood obesity in babies born by cesarean section. Thank you very much. If you want to book your MRCOG Part 3 course, please visit www.onestopmrcog.co.uk. Thank you.